We'll update the lung cancer treatment algorithms with novel antibody drug conjugates. The question is, are you prepared for change? In the next hour, we'll discuss the state of the science, implications for practice, future prospects with some opportunities for questions, participations. This program was approved by the ISLAC 2024 WCLC program as an independent activity in conjunction with WCLC, brought to us through PeerView Live. My name is Stephen Liu. I'm a thoracic medical oncologist at Georgetown University in Washington, D.C. To my immediate right, Professor David Planchard from the Department of Medical Oncology, head of the thoracic group at Gustave Roussy, just outside of Paris, France. And Dr. Melissa Johnson to his right, director of the Lung Cancer Research Program at Sarah Cannon Research Institute in Nashville, Tennessee, USA. I want to thank PeerView for providing this session, Daiichi Sankyo for providing the educational grant for this symposium, and if you haven't already, please use them to all those watching at home or on the recorded viewing. We will select several to take home a gift card for participation, and so scan that QR code with your device. You can visit us at peerview.com/24ADClung to view and download the slides and practice aids, and if you need information, contact information listed below. Our goals for today: to augment your existing knowledge on the efficacy and safety of antibody drug conjugates in the treatment of lung cancer, to equip you with skills for integrating ADCs into individualized treatment plans for patients with lung cancer, and to provide you with guidance for developing effective strategies and manage adverse events associated with novel ADCs in lung cancer. And so let's jump right in with our first polling question. Which dose of trastuzumab deruxtecan, or T-DXd, would you use in treating a patient with HER2 mutant or HER2 overexpressing non-small cell lung cancer? Overexpressing being IHC3. Which dose? Choose your answer. 5.4 mg per kg every 3 weeks, 6.4 Q3, 5.4 Q4, or 6.4 Q4, or not sure. QR code on the right. Please plug your answer in. Professor Planchard has kindly selected all the music you'll hear today.
It's a personal choice, a French choice.
And we'll see our answer shortly. And so a lot of people not sure, David, but it looks like the majority would say 5.4 mg per kg Q3 weeks. We're going to cover this as you go over our next section here. And so we're still seeing some answers clue in, but let's jump right in here today. We're going to talk about antibody drug conjugates, and while it's sort of relatively new for lung cancer, the field has existed throughout oncology. Our first approved antibody drug conjugate was for HER2, and so the first ADC to enter the lung cancer treatment arsenal will be discussed by Professor David Planchard. David?
Thank you so much, Stefan. It's a pleasure to be here and so to talk about the HER2 population, for which until now we didn't get any specific treatment for these populations. So we are testing this patient. In France, for example, since more than 1 decade, we are looking for the HER2 mutation by NGS, but until now we didn't get access to any specific targeted therapy, including ADC, and for sure it's have completely changed the landscape for this population. So what have changed the landscape is the trastuzumab deruxtecan, which is the second generation of ADC after the T-DM1 that do not convince for the lung field, but trastuzumab deruxtecan clearly is completely changing the prognostic of this population. You have the humanized HER2-targeted antibody. The payload is a topoisomerase 1, and you have a specific tetrapeptide cleavable linker. The high dose, I would say, the drug-antibody ratio, which is quite high, 8 in comparison to the previous ADC, and probably a huge effect due to the bystander anti-tumor by this type of ADC. So what have changed the landscape, and the most important trial, is the Destiny Lung01. It's in patient either with HER2 mutation or HER2 overexpressed by immunohistochemistry. Patient had previously received a treatment, chemotherapy plus or minus an immune treatment, with a measurable disease. Asymptomatic CNS were eligible in the trial, and so 2 different cohorts. So we'll focus firstly on the HER2 mutated, and after let's see the HER2 overexpression. For the HER2 mutated, as you can see, it was the high dose of trastuzumab deruxtecan, 6.4 milligrams per kg, every 3 weeks. Primary endpoint was overall response rate. And this is quite amazing. When you see this type of waterfall plot in previously treated patients with a HER2 mutation, you can see overall response rate 55%. It was whatever the type of HER2 mutation, but mainly exon 20 insertion. And you can see on the bottom, we also looked at the magnitude of benefit according to the HER2 protein expression, the HER2 gene amplification, and either if patient previously received another TKI targeting HER2, whatever, it works. The only things patients shouldn't have received previously another antibody against HER2, included ADC. So that means no other predictive factor. It was mainly exon 20 insertion in this trial. And also, it was highly previously treated population. So you can see the magnitude of benefit, whatever, if patient previously received 2 or less prior line of treatment, or if previously patient received more than 2 prior line of treatment, you can see a huge benefit in non-small cell lung cancer with an HER2 mutation. Translation in a benefit, I would say yes, 8.2 months, and overall survival in this previously treated patient also, median OS 17.8 months. What about the toxicity? It's not like a targeted therapy. Finally, you will have the toxicity you can have with chemotherapy. It's mainly digestive toxicity, hematological toxicity, as you can see. So you need to prevent this type of toxicity. You need to inform patient, and for sure, like the alopecia, it's not a targeted treatment. You will have the side effect of chemotherapy in 50%. You have the alopecia in the patient treated in the trial. It's mainly grade 1 or grade 2, so it's not an issue. We know how to manage this type of toxicity. The most interesting things to keep in mind, and particularly toxicity of interest, are the pneumonitis or ILD. You can see in this first trial, it was quite high, around 26% of ILD, despite it was mainly grade 1 or grade 2 toxicity, but for sure, this is something we should keep in mind. So that means toxicity, is it related to the drug, as it might be related like a chemotherapy drug? I would say yes. And the DESTINY-Lung02 have compared 2 different dosage of trastuzumab deruxtecan. So the previous dosage of 6.4 milligrams per kg every 3 weeks, which was compared to 5.4 milligrams per kg every 3 weeks. It's a randomized trial, it's a non-comparative trial, so we are not supposed to compare the magnitude of benefit, but we all compare the result finally. Same population, previously treated with an HER2 mutation, primary endpoint, overall response rate, completely confirm what have been previously observed. Huge benefit in terms of response rate. You can see on the top 5.4 milligrams per kg, response rate 49%. On the bottom, overall response rate 5.6%. At 6.4 milligrams per kg, so clearly it works, same magnitude of benefit, even if you have a lower dose of trastuzumab deruxtecan. Again, whatever the HER2 protein expression, whatever if patient has a HER2 amplification, you have the same magnitude of benefit with the trastuzumab deruxtecan. Translation benefit, PFS, overall survival, you can see completely superposable curves in terms of PFS, OS, whatever the dosage level. So that means same magnitude of benefit. Do we influence the toxicity to reduce the dose of trastuzumab deruxtecan? The answer is yes, particularly if you just focus on the grade 3 or higher. You can see on the left with the lower dose level, 31.7% versus 58% at 6.4 milligrams per kg. So clearly, in terms of safety, you impact, as we might impact the dose with chemotherapy. Do we impact in terms of pneumonitis, ILD? The answer is yes also. You can see around 6% at the lower dose, at the 14%. So clearly, same magnitude of benefit, better safety profile at 5.4 milligrams per kg every 3 weeks. So this is the recommended dosage for the trastuzumab deruxtecan, as we do in the breast. Efficiency on the brain mets. This is something important for all the drug, and particularly for this supposed to be large molecule ADC. And so it's a retrospective pool analysis in the DESTINY-Lung01, DESTINY-Lung02. Patient asymptomatic, untreated brain mets were allowed to enter in the trial. And so we pooled 2 trials according to the dose level, 5.4 milligrams per kg or 6.4 milligrams per kg. And whatever, in terms of baseline, measurable brain mets at baseline, you can see on the left at 5.4 milligrams per kg, intracranial confirmed overall response rate, 50%. On the right, 6.4 milligrams per kg, 30% intracranial confirmed response. So clearly it works. You can see the waterfall plot. You have a huge benefit, huge tumor shrinkage on the brain met. So clearly this population responds to the brain when they have an HER2 mutation. So currently this is approved by the FDA in previously treated patients with HER2 mutation. It's also approved by the EMA, previously treated patient, HER2 mutation. This is probably currently, and I think this is the best option, 5.4 milligrams per kg every 3 weeks. The next step, can I push the drug, can I push the ADC in first line of treatment? Currently, we don't have enough data. So we have this trial, the DESTINY-Lung04, which is currently ongoing. Initially, it was particularly to look to the PFS, but finally, they still recruit patients to try to show a benefit in overall survival, which will be the best way to confirm the benefit in first line. So it's randomized chemotherapy plus immunotherapy versus trastuzumab deruxtecan in monotherapy. Unfortunately, if you have the trial open, and we have the trial open at Gustave Roussy, for example, there is no crossover, which is quite challenging for the patient if they get chemotherapy and immunotherapy, finally, to not get access to trastuzumab deruxtecan in second line when we see the magnitude of benefit. And I think this is something that might be an issue, but whatever, they want the OS, but we have to discuss with the pharma, and it's always challenging for the patient. So HER2 mutated, we have a standard of care nowadays with trastuzumab deruxtecan in previously treated patients. What about the other population, patients that overexpress HER2 by immunohistochemistry? Depending on the cutoff, it's probably around 5 to 20% of non-small cell lung cancer, we have an overexpression of HER2 by immunohistochemistry. In the DESTINY-Lung01, it was immunohistochemistry EHE 2+ or 3+ that were eligible in the trial. And you can see two different dose levels, the cohort 1, 6.4 milligrams per kg, and the cohort 1A, 5.4 milligrams per kg. And you see it works. It works in this population who are HER2 positive, no specific HER2 mutation, 26% response in cohort 1, and 34% over response rate in cohort 1A. So clearly you have a signal of efficiency, which is also translated in a benefit in PFS, around 6 months median PFS in both cohorts. So that means currently it's clearly a new option, and particularly if you look the patients that were immunohistochemistry 2+ and 3+, if we just identify the patient who are immunohistochemistry 3+, the response rate was 52%. It's a small number of patients, so we have to take it by caution, but whatever. You have on the left also the DESTINY-PanTumor02, 111 patients, you have around 51% response rate, and on the right, the DESTINY-CRC, you have 46% response rate. So you can see you replicate the magnitude of benefit in these patients who are HER2 positive, whatever the histological type. And so recently, the FDA approved the trastuzumab deruxtecan, whatever the tumor type, in solid tumor previously treated for which you consider there is no alternative treatment to receive the trastuzumab deruxtecan. So it's a new way to administer a new indication for the trastuzumab deruxtecan. Currently in Europe, for example, unfortunately, we don't have any access in this population who are HER2 overexpressed, but for sure, it might change the landscape. And you will see tomorrow also an additional presentation from the DESTINY-Lung03. It's a multi-cohort trial, and for which we studied the combination of trastuzumab deruxtecan, plus or minus durvalumab, plus or minus chemotherapy, first line, second line, in patients who are HER2 positive, and we'll present tomorrow a cohort of patients, monotherapy with trastuzumab deruxtecan. I can only show you the abstract at 5.4 milligrams per kg in this population, HER2 positive, non-small cell lung cancer. We confirmed the benefit over response rate, 44%, median PFS, 8.2 months in these patients who are HER2 positive. So clearly, it should be considered a new option in these patients who are HER2 positive by immunohistochemistry with no specific actionable genomic alteration, which is quite nice, finally, for our patient. And so this is where we have for the HER2, a new option, waiting the challenger, other ADC, and probably other TKI in development to target this population who are HER2 positive, immunohistochemistry, and HER2 mutated.
Outstanding. We're getting great questions. Please do key in whatever questions you have on your app here. But just to reiterate here, we reward people for going back, looking at the literature in clinic. But if you were to pull the first T-DXd paper from the New England Journal of Medicine, that's not the dose we use. The dose really is from Destiny Lung 2, 5.4 mg per kg every 3 weeks. Similar efficacy, much safer. David, one interesting question here has to do with mechanism. When you think of antibody-drug conjugates, we have an antibody binding to an antigen. We might expect that in a tumor overexpressing, we'd see more activity than in a HER2 mutant. And so why do we see more activity in the mutant than the IHC?
I would say it's probably two ways, because one way you target the HER2, so that means you deliver the payload, but on the other way, you block your oncogenic driver activation. So that means there is two pathways, blocking the HER2 activation, and the other things, finally, you deliver chemotherapy. So you can imagine something like for the EGFR, for which you make an association of TICI plus chemotherapy together, like the FLORA2 trial, in one way with one ADC. And so that's why clearly the response rate is higher for these populations who are HER2 mutated.
Well, there's a question here asks about using this drug in the first-line setting. Now, you outlined the trial, the phase 3 study that's going to go on forward, but if we just sort of think practically, if we had access to everything, you show that waterfall plot, it looked pretty impressive. Melissa, does this look like a frontline drug to you?
You know, there aren't many ADCs that are where lung cancer patients or lung cancer physicians have as much experience as trastuzumab deruxtecan. The response rate that David showed us was 60+%, and we expect that it might be a little higher than that, which we would expect with chemotherapy and immune therapy in this group. Likewise, the duration of this response is starting to look more promising than what we can expect with chemo IO, and so I think that it's going to give chemoimmunotherapy a run for its money in the front line.
I completely agree. It's got that sort of familiar shape of waterfall plot where you have that confidence that this drug is going to work, and so certainly we look forward to seeing those data. Here's an interesting question, David. Any sort of relationship between HER2 mutation and HER2 overexpression?
I would say you can have the HER2 mutated and patient who overexpress HER2 in around 20%, but whatever. That means I would say if you have HER2 mutation, in this case, this is a priority. When you have an actionable genomic alteration, whatever the other expression of the protein, same as for the EGFR. In this case, the priority, this is the mutation. After, I don't think, and it was not reported in the Destiny Lung 1 trial, that patients who are HER2 mutated, HER2 positive, or hyperexpression have a higher benefit of trastuzumab deruxtecan. So in this case, this is the molecular alteration and not the expression, which is important in this population.
You touched on something, I think, you outlined that really well. We think of T-DXd as very high response rates. This is clearly an effective targeted agent. When we think of targeted drugs in general, when we think of the oral TKIs, we think of a kind of a different toxicity profile, sort of a lot of tolerance. But here, even though certainly this seems like a tolerable drug, the side effects seem to align a lot more closely to chemotherapy. Melissa, when you're giving this drug, how do you counsel patients on sort of what to expect from a safety standpoint?
We do talk about these antibody drug conjugates as if they are next generation chemotherapy, chemo 2.0. I think the fact that we are pre-medicating with 3 drug regimens to prevent nausea, for example, that is more consistent with a chemotherapy than it is with a targeted therapy. Same with alopecia. I will say that in my patients that have had both, they tend to say that trastuzumab deruxtecan, for example, is better tolerated, that they think it's easier, and whether that's perception or reality, that's what they believe. But I think in my practice, it feels more like chemotherapy than a targeted agent. What do you think, Debbie?
I totally agree, and probably it's particularly the challenge in first line of treatment. So that means how long the patient will be able to support this type of treatment if you have a long duration of exposure. And probably the challenger will be the HER2 TICI, which are coming. And we might think probably in first line of treatment TICI, and why not to keep the trastuzumab deruxtecan beyond? So it's still a question. So this is the duration of exposure. Are we changing probably the landscape of toxicity, first line versus second line? And for sure, for the first line, we need to have a longer exposure with trastuzumab deruxtecan. Perhaps we need to have a better adaptation of the dose, and don't hesitate to quickly decrease the dose level in the responder patient to try to avoid the toxicity, because for the patient it can be impactful in terms of
If you could please take a moment to answer the follow-up question on your device as we go forward with a couple more questions, really good questions coming in already here. David, you mentioned this morning at the presidential plenary, we saw 2 HER2 tyrosine kinase inhibitors with pretty impressive efficacy. Question here is, are these drugs we can use in sequence, or do you expect the resistance to sort of be all-encompassing here?
I would say I'm quite comfortable to imagine that the trastuzumab deruxtecan can be used with no issue after a TKI HER2, because whatever the mechanism of resistance, it's an antibody, and in this case, it might work. On the other side, we don't know exactly the mechanism of resistance after trastuzumab deruxtecan. Does it change the protein, and does this induce a specific mutation for which the HER2 TKI will not be efficient? This is another question. We have the same question for the EGFR. With amivantamab and lazertinib, for example, post-TKI and so on. So I think the TKI at resistance works. TKI first line and after to use ADC, it's another question.
I think we're in a better position now than before when we have multiple agents available and we expect patients to go through multiple lines of treatment. We then need to think of not just the current study, but sort of the sequence of treatment, how we can further personalize that. We're going to leave some more opportunities for questions at the end, but I'm going to move on to the next section. If we could pull out our device again and tackle this polling question: which of the following biomarkers is associated with response to patritumab deruxtecan? That's HER3-DXd in patients with non-small cell lung cancer. Is it HER3 overexpression by C? Is it HER3 amplification by FISH? HER3 mutations by NGS? All of the above, none of the above, or not sure? Please key in your answer. David, you want to tell us about this next song you've chosen?
I will not tell.
All right, a lot of people unsure about this. We're going to change that with our next section. So moving on to HER3, it really is an evolving area. It's my pleasure to introduce our next speaker here on our far right, targeting HER3, an ADC approach in addressing unmet needs in EGFR mutated lung cancer, Dr. Melissa Johnson from Sarah Cannon. Melissa?
Thanks, Stephen. It's a pleasure to be with you today. We're going to jump right in. I'm going to talk to you about 3 studies that use patritumab deruxtecan, much in the same pattern as David used. First, let's look at the phase 1 data that initially showed us a signal in these patients that were evaluated. They were all EGFR mutated non-small cell lung cancer, and they were treated at a variety of doses with a drug that was at the time U3-1402. Now we refer to it as patritumab deruxtecan, an antibody drug conjugate directed against HER3 with a DAR of 7.8. So in some ways very similar to the trastuzumab deruxtecan. In the phase 1 group of patients, a response rate of 41%, and very nicely shown at the bottom of the slide, again to the point that Professor Planchard made, that these drugs seem to work in a variety of acquired resistance mutations. So all of the patients that were treated in this phase 1 trial had previously been treated with osimertinib, and all of them had previously received platinum. So this was a fairly focused population for a phase 1 trial. The anti-tumor activity, again from the phase 1 trial, shows a PFS of 6.4 months, so promising, and a median overall survival 16.2 months. So versus chemotherapy, this was looking and continues to look really good. A year ago, we heard the results of the second trial, 2-arm phase 2 trial named HERTHENA-Lung-01, in which patritumab deruxtecan was treated in patients who had previously received osimertinib as well as a platinum-based chemotherapy to receive 1 of 2 doses of patritumab. You'll see a pattern emerging with a primary endpoint of objective response rates, and patients with inactive or previously treated asymptomatic brain metastasis were allowed. We'll come back to that. So patients were randomized to 5.6 milligrams per kilogram or an up-titration of dose from a smaller dose to a bigger dose, testing the hypothesis, could you mitigate some of the nausea by starting low if the nausea was Cmax associated? In point of fact, though, 5.6 milligrams per kilogram once every 3 weeks was better tolerated, and so the bottom up-titration design was discarded, and enrollment continued. There were 225 patients treated in HER3-Lung 01. And here you see the primary endpoint response rate, irrespective of subset, was 30%, 29.8% in the prior EGFR TKI. And for the subset that previously received osimertinib, as in particular the third generation EGFR inhibitor plus platinum-based chemotherapy, again, response rate almost 30%. With the duration of response of 6 months, PFS just shy of that, 5.5 months, and a median overall survival of 12 months. You see that as we look on the right at the objective response rate by patient and disease characteristics, that in general this was consistent across the subgroups evaluated, perhaps smaller numbers of the non-white patients, really no characteristic that would predict for a group that wouldn't respond. And so we start to, and then a very nice waterfall plot, again demonstrating now whether the required resistance mechanism is EGFR dependent or EGFR independent. Patritumab deruxtecan is showing responses in 30% and another 30% with stable disease. So you say, okay, so how does that stack up against chemotherapy? Maybe one of the best contemporary examples we have is Keynote 789, where patients got chemoimmuno versus chemotherapy with carbo-pem post osimertinib, and in that group of patients, the response rate was 30%. And in that group of patients, the median PFS was 6 months. So this is stacking up in a very similar way to that data set. And so one other thing that we, of course, are looking for in these antibody-drug conjugates is any biomarker that we might be able to use. Once again, we see sort of a confusing lack of association with baseline HER3 membrane H-score. Doesn't seem to predict. So we're back to the drawing board on the biomarker once again. The management, the safety profile here is both manageable and tolerable. You see, in contrast to trastuzumab deruxtecan, this also has some chemotherapy-like side effects, nausea and decreased appetite, as well as some hematologic side effects associated with the payload, thrombocytopenia and neutropenia happening in roughly 50% of patients. So in some ways, actually, I find this to be better tolerated than some of the other antibody-drug conjugates in the class, but they all are well tolerated in comparison, I would say, to the chemotherapy. What about the brain met question? Patients had to have their brain mets treated. In the majority of patients, they were treated or asymptomatic. There were 30 patients that had small asymptomatic brain metastasis at baseline that were included who had not had prior radiotherapy. And in that group of patients, so of the 225, 30 patients, the response rate was 30% intracranially. I mean, I think that stacks up with the response rate systemically of 30%. So to me, this says that this drug likely has activity. It was in the same session as Professor Planchard's brain metastasis data. That is more robust numbers, but showing response rate as high as 50%. So certainly something that we'll continue to need more experience with, but cautiously optimistic for patients with brain metastasis. And so here we reach the pivotal trial. Let me say before I get there, based on the HER3-Lung 01, the application for approval went to the FDA, and the PDUFA date was in June, right after ASCO. And that June 26th day came and went, and we learned that there was some issue, third-party manufacturing issue that needed to be evaluated further. So we don't yet have an approval, and we thought that we may. So this phase 3 HERTHENA-Lung02 trial that's been fully enrolled, but for which we haven't seen the results, may be more relevant than maybe we would have thought in the past. Now, in this trial, patients are newly diagnosed. They've been treated with 1 to 2 prior lines of TKI therapy only, but no to patritumab deruxtecan or platinum-based chemotherapy, large trial, 500 patients. And the primary endpoint is PFS. So we await the results of this trial to see how we might begin to sequence patients with EGFR mutations with chemotherapy or with ADC after osimertinib in light of the breakthroughs in the front line over the last year. It's a very complicated space with a lot of opportunity for dancing around in lines of therapy. Just thought I'd mention, though, that there are other companies that are evaluating HER3 antibody drug conjugates. We'll hear in a minute about the cadre of companies that are evaluating TROP2 antibody drug conjugates. This is one example, and there are others, of another sort of up-and-coming, second to the clinic HER3 ADC made by Hongru, a Chinese company. This phase 1 experience was reported at ESMO last year, in which we see a number of doses evaluated, all comers in the phase 1 trial, not just patients with EGFR mutations. You see 36 non-small cell lung cancer patients and most of those were EGFR mutated, were included. Majority had been treated with a 3rd generation EGFR TKI. And here's the initial safety here, response rate of 30%, so tracking along with what we're coming to expect. This looks very similar in terms of toxicity, with anemia, neutropenia, and nausea being the most expected side effects that we're used to managing with both chemotherapy and ADCs at this point. So we'll want to continue to evaluate this and other molecules, and to be continued.
Thank you, Melissa. Well done. We're getting a lot of really good questions here. This one's a little sophisticated here. David, when we think of the use of immunotherapy and targeted therapy, we know if we give immunotherapy before targeted therapy in EGFR, it seems to increase toxicity. Is the same true for ADCs?
I would say, as it's mainly as a chemotherapy, generally you do not increase the toxicity and the safety, despite you have a longer half-life of this type of ADC. So that means for me, it's not an issue after, even if you want to expose patients with a TKI and so on, you don't have the toxicity generally as you may have with immune treatment, for which for sure generally patients with actionable genomic alteration might do not respond to immune treatment, and for sure if you had specific TKI, you may have toxicity, liver toxicity for the HALK, you may have the pulmonary toxicity for the EGFR TKI like osimertinib. With the ADC, it's not an issue. So that means after we can think also to make combinations. So that means why not to have osimertinib plus patritumab deruxtecan in combination in first line, like a FLORA2 trial, instead to have platinum-based chemotherapy. And so this is probably the next step for the ADC and in this population, but that's really nice.
Melissa, they're exploring that, correct?
Yes, and it is interesting actually to the question that was asked. We are even exploring combinations of immunotherapy and antibody drug conjugates. So these two pair together nicely, and we don't seem to see an increase in interstitial lung disease even when they're given together. But David makes a really good point. I think it's easy for us to single out one targeted inhibitor or another that seems to show a signal of transaminase elevation or ILD, when really I think what we're learning is the immunotherapy followed by the TKI, and it could be many or other small molecules, seems to be the pattern with which the ILD crops back up again when there's a little bit of a hangover. So that will again influence the sequence of therapies as we become more sophisticated in the number of drugs that we can pull from at any time.
This question here I think touches on an interesting point. The question really is, we're exploring this HER3 ADC in this TKI-resistant population. And so, Melissa, is HER3 upregulated, and is that mediating resistance? Sort of what's the link there? Why are we studying this in EGFR specifically?
Yeah, that is a sophisticated question, and I think there is more than one answer. First of all, remember that in order to dimerize and activate, the EGFR receptor has to dimerize with another EGFR receptor. So that can be EGFR1, it can be EGFR2, or it can be EGFR or HER3. So there is some thought that wherever you see mutant EGFR being expressed, you might also find HER3. We also have learned over time, however, that HER3 amplification, as well as other receptor tyrosine kinases, is a mechanism of resistance. And so for that was the initial reason, I believe, that the EGFR patients were selected. Now, it does beg the question, is that the only place that you find HER3 overexpression? And of course the answer is no there. So how else we might deploy drugs like patritumab deruxtecan is an interesting area that I'm sure we'll see more.
And probably one point, the issue with all these biomarkers for the expression of the protein generally was done on archival tissue biopsy. So that means the patient will receive multiple lines of treatment, chemotherapy, immunotherapy, and I don't know, TKI, and finally you are looking the baseline before all the treatment, you are looking the expression of the protein. So that means I don't know finally if we perform fresh tissue biopsy, we might change the expression of the HER3. So we have to take it by cautious. It's not fresh tissue biopsy on all these trials. So that might be an issue because you can modulate the expression of the protein on the cell surface.
I like this drug. I'm excited about its versatility. As we move on, if you could scan the QR code and type in that follow-up question, I think the lack of biomarker is something we can still work on. It's going to be a little more complex. Melissa, you mentioned up front the DAR, the drug-antibody ratio. You mentioned there are a few HER3 ADCs. We saw the SHR. We have DL1305. There are several others in production and development. And this is a setting where we might think of PD-1 and PD-L1 drugs as kind of interchangeable. Not so with the ADCs, right?
Oh, it's so true. I think the DAR is just even scratching the surface about how these drugs are different, but it does seem to be the linker that is the proprietary piece that's different and allows some of the payload to be cleaved or not, and that probably is more important than we understand. And so it probably will be possible to be best in class even when you're not first in class here, which is maybe not the paradigm that we saw with PD-1 and PD-L1.
We've got some great questions already, some leaders for the prizes from peer review at the end. One polling question here, if you could pull out your device, in which the following histologic subgroups has datopotamab deruxtecan shown the most promise? Squamous cell, adenocarcinoma, or small cell? Please key in your answer. V, let me tackle one of these other questions while people are typing in their answer. Someone asked when we think of these ADCs, both HER2 and HER3, we are seeing some CNS activity. But these are pretty big molecules. Were you surprised that they had CNS activity?
I didn't know who you were asking. I was. Initially, the T-DXd trial that we'll talk about next excluded patients with brain metastasis. So that often biases an investigator to think that maybe there won't be activity. But there are always times where where you have a patient that has a tiny little something that might be a brain metastasis, but it's way too small to know for sure. And you see a couple of those go away, and you start to wonder whether there might be activity.
After, I am not surprised because mainly you have a cleavable linker and you have the bystander effect. So finally, the efficiency on the brain mets can be the efficiency you may observe with chemotherapy. So that's why even if it's a big molecule, you don't need all the molecule ADC to go in the brain. Just if you release the payload in the brain and you have efficiency on the tumor cells, you are efficient and you see the response on the brain. So that's why it's not really surprising. And you have potentially also all the immune activation that might be due to the ADC, and that might also have an efficiency on the brain mets.
These are complex agents, I think pleasantly seeing some CNS activity. We're going to move on to our next section here. and that is really talking about TROP2, evolving evidence on ADCs in different treatment settings and patient populations. Let's start with data in the second line, which is the most robust data, and we saw an update in this very room. TROPION-PanTumor1 looked at datopotamab deruxtecan, a TROP2 ADC, in various tumors and non-small cell lung cancer. The early signal showed response rates around 20 to 30%, some quite durable, so some early signals of activity leading to TROPION-Lung01, a randomized phase 3 study for patients who had already had platinum-based chemotherapy and immunotherapy. Patients with AGA or actionable genomic alterations like EGFR ALK were required to have targeted therapy. We see patients were randomized to datopotamab DXd, datopotamab deruxtecan 6 mg per kg every 3 weeks, or standard docetaxel 75 mg per meter squared every 3 weeks, with dual primary endpoints of progression-free survival and overall survival. We saw at ESMO 2023, TROPION-Lung01 progression-free survival in the intent-to-treat population was positive. And so this was a positive study, meeting the first of its dual primary endpoints, with an improvement in PFS here, the hazard ratio 0.75. When we look at these curves, we do see a fairly early separation that's maintained. The curves don't cross. At 9 months, we see 30% progression-free versus 17.8%. We also saw an increase in response rate from 13% with docetaxel to 26% with datopotamab. But what was interesting at the time, and maybe we didn't have a clue as the study was being designed, there was a clear difference in histology. And if we look at the left, we see an even more impressive separation in non-squamous and adenocarcinoma with or without actionable genomic alterations, with an improvement in progression-free survival. Here, a better hazard ratio, 0.63. Here, an even more stark difference in response rate, 12.8% with docetaxel, 31% with datopotamab. Whereas in squame, the opposite. We actually saw a lower progression-free survival, a lower response rate, a hazard ratio of 1.38. Really, this drug not showing the necessary activity in squamous, but showing even more promise in that non-squamous. And if you look at the group without actionable genomic alterations specifically, we still see that PFS hazard ratio 0.71 at the bottom, really meeting the criteria for most of us to show clinical significance and meaning. If we look specifically at an update here from ELCC this year in Prague, we saw the response rate with datopotamab here, 31%, 13% with docetaxel. We saw the hazard ratio 0.63, really persisting with longer follow-up. Now, there are unique toxicities with datopotamab deruxtecan and targeting TROP2. We see some on-target effects like stomatitis in 47%, nausea, and other frequent TRAE, but most of these are grade 1 and 2. We're going to talk a little bit more about toxicity at the end of our presentation here, but we do see some hematologic toxicities. Those, however, much more frequent with docetaxel. No new safety signals here. If we look specifically at some of these AEs of special interest, stomatitis, mucositis, we see that in 54%, but only 6% grade 3. Ocular events like dry eye, keratitis, 19%, but only 2% grade 3, and interstitial lung disease, 8% all grade, only 3% grade 3 or higher, though there were some grade 5 events, so an important toxicity to watch for. Infusion reactions, fortunately, fairly uncommon. We did see more activity in that actionable genomic alteration for sort of various reasons, but in patients with EGFR and ALK alterations, even higher signals with response rates, 36% in that AGA group, but in EGFR specifically, up to 44%. Now, in this room, we had an update on overall survival. We knew from press release that in the intent-to-treat population, the study did not meet its overall survival endpoint, but if we break it down by histology, looking at the left, in non-squamous non-small cell lung cancer, which is really the only area this drug is being pursued, we see that overall survival hazard ratio 0.84, a separation there at a year, 59% versus 53%, whereas in squame, really inferior results to docetaxel. So non-squamous really where this drug is being developed. And so let me sort of ask a direct question. Let me start with Melissa. Melissa, this drug is available today, which it's not, but if it were available today, sort of in light of these data, is this a drug you could reach for after chemoimmunotherapy?
Certainly you can. I think if we're gonna dream big, then we'll dream that along with an approval might come the biomarker that we learned about yesterday in the plenary session. The overall survival is a little bit sobering, that the fact that, you know, those curves are pretty similar and the confidence interval does cross 1. So I think we're going to need to learn who the patients are who should receive this. I think there are patients in this group that probably could get docetaxel as an alternative. And I don't confess today to know what the difference is between those groups, but I don't know that this data is enough to change my practice in everybody.
And you, David?
It will change. I would say probably, what is missing for me, for sure, you have the biomarker. It's still a question, and it's not so easy. This is like the immune treatment. I think it will take time to find the right and the good biomarker for this, because it's so complex for the ADC. The other things, what will be nice is to know what is the sensitivity of patient with docetaxel post-ADC. So that means if I have dato, can after I re-expose patient to docetaxel. So in this case, you had the line of treatment. So that means it's not docetaxel or dato, but it can be docetaxel and dato, and for which you make addition of line of treatment. And in this case, you might bring the benefit for the patient. So I would be much more happy to have access to this treatment. And that's after it's a question of cost. And for sure, yeah, it's slightly disappointing with the overall survival, but it was not pre-planned to look at the histological type in the trial initially. So that's why we have to take it by cautious.
I think we wanted to see more of a signal in survival for sure, but to your point, not powered by histology. This is a drug that really should not be used in squamous lung cancer, at least without the use of any other biomarkers. The survival trends are there, but we don't reach significance. It is a positive study because it met one of its dual primary endpoints. To me, what may factor in if the drug is available is the response rate is 2 to 3 times higher. And so for patients that are symptomatic, sometimes getting a response really does add value. But certainly we have to wait for more data to evolve. We'll see if this drug becomes available. Again, an improvement in progression-free survival, especially in non-squamous histology, a trend towards a survival improvement, but not meeting statistical significance. We'll see if other studies get us there, but a much higher response rate here and a different toxicity profile. Now, we mentioned a little bit about biomarkers. Melissa, I don't want to spend too much time. It's a complex topic here, but Dr. Garasino presented the normalized membrane ratio of TROP2, and how is this different from immunohistochemistry?
Well, I think we've seen now for years that the immunohistochemical stain doesn't correlate with response, and yet with the mechanism of action of all of these drugs, we really want it to. So this is this NMR is a normalized membrane ratio, and I understand it to be a fraction with the membrane over the membrane plus the cytoplasm as a unique way to try to illustrate the fact that this is a dynamic biomarker that's being engulfed and goes into the cell and then is being chopped up by the lysosome and processed. And in this biomarker analysis that was reported yesterday, we see that in the overall biomarker evaluable patient population, that there was a trend towards improved response rate for patients who were NMR positive as compared to those that were NMR negative, and those that had docetaxel also tracked the same. So this is, I think, the first stab at something that we've been wanting for a long time. I'm not a pathologist, but it feels like a step in the right direction, although how this would become a companion diagnostic, I mean, there are people whose job it is to figure that out. And so maybe this will be the springboard for more like work.
I think an important step. There are other TROP2 ADCs, sacituzumab govitecan, a drug approved in breast cancer and others, showed early signals in this basket study with response rates of 15 to 20%. The phase 3 EVOKE study compared sacituzumab to docetaxel in that second-line setting. Here, one primary endpoint, overall survival, and this did not meet its primary endpoint. We see the trend there, hazard ratio 0.84, but not crossing statistical significance. In the subgroup of those who did not have a response to prior immunotherapy, there did seem to be some added benefit, but ultimately the study did not meet its primary endpoint. This breakdown is not necessarily one we often reach for, but it was pre-specified, and so there is some thought as to why this was included. However, overall, the study did not meet its primary endpoint. One wonders if this is the best way to use the drug, though, and because of how ADCs work and their bystander effect, how they can disrupt the immune microenvironment architecture, would they be better served in the frontline setting? We're seeing explorations of datopotamab deruxtecan, a TROP2 ADC with platinum or without platinum, but also with immunotherapy, either pembrolizumab, durvalumab. And we're seeing overall across multiple studies fairly high response rates without adding sort of unexpected toxicity. We do see the stomatitis, the ocular effects we saw in early studies, the hematologic side effects largely from the chemotherapy, but also the ADC. But these do seem to be tolerable, and we'll have randomized studies ongoing. We've seen EVOKE-2 look at sacituzumab also in the frontline setting, and you're seeing trends. The sense is, will this be a better partner for immunotherapy than chemotherapy? And would the lasting legacy of ADCs really be a way to get more immune-mediated anti-tumor responses? Do these drugs belong in the first-line setting? And ongoing studies will help answer that. As we talked about with other HER3 ADCs, as also with TROP2, there are multiple others in development. Here's one, sacituzumab tirumatican. Also mentioned these are extremely fun to say, so I encourage you to practice at home. But we'll see these combinations go in the frontline setting as well. And so if you could scan this QR and tackle that question we had asked previously, we are going to move full steam ahead and look at the future of ADCs. Luminosity is a study looking at telisotuzumab vedotin, and this was studied in multiple cohorts, but really the non-squamous EGFR wild-type group is where this c-Met ADC has shown its promise, and with higher c-Met expression, we're seeing greater activity in that EGFR wild-type. So stay tuned. Will c-Met positive lung cancer be another subgroup we can target with an ADC? There are different toxicities with this agent. Peripheral neuropathy and blurry vision are important ones. And for a lot of these ADCs, we do have to partner with our ophthalmology colleagues. Melissa, is that sometimes a challenge?
Well, no. As long as you can find partners that are good communicators, that sometimes we find giving them a report card to check so that they have to do less work in order for the oncologist to understand what the concerning findings might be has helped us zero in on things that we should be worried about. You know, it is, I think, a toxicity that we see with antibody drug conjugates approved in other indications, right? For myeloma patients, for breast cancer patients, for ovarian cancer patients, for example. And so I think as lung cancer doctors, this is the first time that we're having to grapple with it, but docs that see everything are used to managing it, I would say.
Absolutely.
So,
we shouldn't be intimidated by the ophthalmologic toxicities, and they can generally be low grade and well managed. We saw some activity in small cell, B7H3, highly expressed in small cell. We saw response rates in early studies north of 50% at this meeting. Dr. Charlie Rudin presented the phase 2 IDEATE study looking at 2 different doses, and we saw that higher dose actually with a much higher response rate here, 55% versus 26%. PFS, OS tracking in this small trial, but really it's IDEATE Lung 2. Will a B7H3 ADC replace topotecan finally for small cell lung cancer as the emerging agent? We'll have to stay tuned. There were some toxicities with T-DXd though, and so we'll have to watch that very carefully. Another ADC in this space, ABBV-706, that's a CES6 ADC showing pretty high response rates. Single arm, we don't have comparators, and we need to wait how these ADCs emerge, and so they're being studied, not standard options now or standards right now. Lurbinectedin, topotecan, tarlatamab approved for small cell, but watch for ADCs in this previously treated and in the frontline setting as well. We'll tackle that question again. Here's the QR code to answer this question, but we do have a few cases. I see a lot of other questions coming in. These are great questions, but let's talk about this case. Here's a patient with an incidental lung nodule, 2.8 centimeters, spiculated left lower lobe lung mass, had surgery, adjuvant chemotherapy, and then unfortunately developed metastases. What will we do here for this HER2 mutant lung cancer after chemotherapy? And so, David, if this patient who has a HER2 exon 20 mutation had adjuvant chemotherapy and then progressed with metastatic disease, would you think about an ADC here?
I would say for sure, I will go for trastuzumab deruxtecan. I think this is probably the best place and the best room for this population with HER2 mutated, as we have seen, 55% response rate and median PFS 8 months. So I would go with highly confident with this type of ADC, and I think this is currently with no, I would say with no discussion. After probably we always can discuss the re-challenge with the platinum salt depending the time of relapse in this population, so it might be another option, but in second line of treatment, I'm much more confident than docetaxel in this population for sure.
Interstitial lung disease, not a common toxicity, but one that we do have to be aware of because early recognition can help prevent complications. It's important we screen our patients for ILD. We tell patients to report certain symptoms. If we have suspicion, we want to scan, a CT scan, really synergy between patient, caregivers, family members, and if we do see pneumonitis, we want to suspend treatment. Early integration and implementation of steroids can really avoid bad outcomes. ILD is a significant toxicity, but one we're not afraid of as long as we recognize these early and intervene appropriately. Let's make a little variation in this case here. This is a different patient, no actionable alterations, high PD-L1, gets carboplatin-pembro, partial response, but then progresses. If this patient received T-DXd and had this side effect here, how would we react? So, Melissa, what are we looking at here at the bottom right?
Stephen, we're looking at periocular inflammation. You see redness in the eyelids as well as a little bit in the sclera as well. This would absolutely be somebody that I would send to my ophthalmology colleague for evaluation.
Yeah, ocular, we really want to use artificial tears. We want preservative-free artificial tears. There's no reason not to give that to everybody, but in integrating our ophthalmology colleagues early is important. Melissa, what's this picture at the bottom right here?
Stephen, this is mucositis. In a patient of mine who had been treated with a TROP2 ADC. And this is the reason that we need to aggressively recommend not just ocular prophylaxis with preservative-free drops, but also mouthwashes.
And so here again, download these slides for some guidelines on prophylaxis, diagnosis, and management. Supportive care is important in minimizing the impact of these toxicities on quality of life. This is a case for a patient who had osimertinib for an EGFR exon 21 L858R mutation, and then had progressed after TKI, and also had chemotherapy. And so, Melissa, is this the optimal setting, you think, for a HER3 ADC?
I mean, I think that's what we're going to find out, right, with our with the HERTHENA-Lung02 trial. Of course, in HERTHENA-Lung02, patients were randomized to either platinum or HER3 ADC patritumab. So we'll figure out which sequence, but this is absolutely someone that you could think of patritumab in.
David, very quickly, there's one question here. Do you think that prior immunotherapy impacts the rate of pneumonitis?
Until now, I would say if we looked for the trastuzumab deruxtecan, it does not seem to be correlated. So that means it's not only the patient that receive prior immune treatment that had the ILD or do not receive immune treatment. So I would say there is no correlation nowadays with the immune treatment. So we need to look at, but no correlation.
We've had some great questions here, and we are really at time. Feel free to download the slides here. If you visit us at peerview.com/24ADC-Lung, there's a post-test and evaluation for your CME credit. You can download this slide deck for your reference. You can also watch a replay of this event if you like. I'd like to thank my expert colleagues to the right, Professor David Planchard, Dr. Melissa Johnson. Thanks everyone for attending here, and hope to see you again at the meeting soon. Bye-bye.
Thank you.